going to go ahead and start. But before, I would like to introduce our speaker today. And our speaker, Dr. Ram, is actually an accomplished surgeon. He's an MD, he's a pediatric plastic surgeon with Oklahoma Children's Hospital, and is also a professor in the Department of Surgery at OU, College of Medicine. His areas of pediatric expertise include cleft lip and palate, canyon synostosis, Pierre-Robin sequence, and midface hypoplasia. Dr. Ram earned his medical degree from AUB, and he had also his residency at AUB as well. He did complete a fellowship in craniofacial surgery at Children's Hospital of Wisconsin, Milwaukee. He's also an avid lover, actually, of technology. He is involved in AI, machine learning, as well as AR, VR. He's also a staunch LAU supporter, and he's currently supporting our undergrad research initiatives. Chris, the floor is yours. Go ahead.
Good afternoon, everyone. It is the morning after Thanksgiving here, and I bring you my best wishes. We will spend the next 45 minutes talking about this new technology called augmented reality, its promises, its many limitations, and talk a little bit about the underlying technology. By the end of the talk, I will ask you to consider the potential of this technology and how it involves almost all the disciplines of the arts and the sciences. As a disclaimer, I am a founder of Chironetic, a company that develops medical extended reality. As a second disclaimer, everything we'll be talking about, including nomenclature, indications, designations, the underlying technology, is being developed as we speak. Questions such as, how do you measure a virtual object, are still being answered. In Europe, you will hear this mostly addressed as holomedicine, and Germany is taking a lead on this. In the US, it is now called medical extended reality. The FDA has issued its first intent document a few months ago, but we still have no guidance document from the FDA yet. So this is fresh off the press. Let's start with some definitions. Many of you are now familiar with virtual reality, those bulky, opaque goggles that you put on. Augmented reality, on the other hand, are see-through goggles. They are more comfortable, they are easily worn for hours at a time, and will not cause dizziness, disorientation, or headaches. They actually fit very well with the surgical workflow, and they feel like oversized splash guards that are commonly worn at surgery. This mixture of virtual and real is called augmented reality. Sometimes you have to do a double take to identify what's real and what's not. This image is at the heart of what we'll talk about today. When a surgeon is operating and wants to consult a radiologic or other medical information, they have to interrupt their current action, look away from the surgical field, sometimes step away, identify the relevant data, and then come back to the surgical field and reapply it to that field. This cognitive disruption is the problem that augmented reality will address. So, the first intuitive approach is to extract information from a preoperative CT scan, overlay that information over the patient's real anatomy, and voila, you have X-ray vision. The earliest surgical applications involved trying to put catheters in cavities such as this VP shunt paper. But this is not what we will be talking about today. This is called stereotactic surgery or surgical navigation. There are several existing solutions that work fairly well. This is one of them. Many of us surgeons use this routinely in the operating room. The system uses these cameras here to track these reflective balls here on the right side and determine the 3D position of these balls and guide surgery. On the right side is actually a surgical robot. This robot, when it has this information, can actually do most of what a surgeon does in those circumstances. That's why it's more towards robotic surgery than stereotactic. Instead, today we will focus is how to incorporate this technology with your existing surgical armamentarium. In this image, you see an instrument set with common everyday surgical tools. And here on the wrist is the only virtual tool. This is the logo for the Microsoft HoloLens. You tap this logo and with your right index finger and you open your virtual toolbox. And when you open your toolbox, this is usually the first step. The first step is aligning the virtual and the real. Something called registration. Once you've aligned the surface anatomy, the underlying anatomy usually follows. This patient, for example, is undergoing a repeat resection of a facial tumor, a neurofibroma in this case, that will require dissection between very enlarged vessels, many nerves, removal and reconstruction of part of her lower jaw, including the temporomandibular joint. The idea here is that you can selectively display your relevant structures, plan your incision, and avoid these major vessels. On the side table, we are using this virtual model to bend and contour a reconstruction plate to her native anatomy. This purple thing here is the reconstruction plate, and this is the virtual model above. Everybody seeing okay?
Yes, excellent.
You can also manipulate the virtual model to visualize your reconstruction from all angles. Many of the surgeons in attendance will already do this, but they'll do it with 3D printed models. There are advantages to each technology, but these virtual models that we're using have almost no wait time. You don't have to wait for them to print. They are almost immediately available, and they are infinitely adjustable. Another technical advantage, and the surgeons will recognize this, is that you can actually bend your plate inside the contour of the virtual model. While the physical model, your plate sits outside of the model and could be a problem if you're using a thicker plate. It can be felt under the skin. In this particular case, after removing the tumor, I had some bleeding from this area here at the base of the skull. And the hologram overlay was very useful to me to ensure that I was not accidentally ligating a major vein and causing problems. And it gave me much more confidence in controlling the bleeding in this case. As far as rebuilding the missing jaw segment, we visually checked the placement of the bone cuts to confirm that they are in accordance with the surgical plan. These are the missing portions that we need. We then used those virtual models to get the needed segments of bone from the leg bone. We can currently do this with 3D printed cutting guides, but those are somewhat bulky. They require a more extensive dissection of the bone and cannot be adjusted in the operative field, depending on what you find there. For example, here, if you find a perforating vessel in the way of the bone cuts, you can just simply move your model up and down the bone, whereas you cannot do that with the cutting guides. Typically, to put these pieces together, I would have needed a much bigger incision, something I was not excited about in this very vascular tumor. Augmented reality gives the surgeon increased confidence in his actions, and I was able to complete the reconstruction with a relatively small approach. Here we're checking that the teeth and the joints line up properly. And this is how it looks like at the end. So this technology is now part of our routine. There are several practical advantages also. You have a camera that is properly positioned, ideally on your head, and you can take photos or videos using only voice commands. You can arrange virtual TVs and virtual screens in your operating room anywhere you want without having to worry about cables, the supporting boom, etc. And overall, it just acts as a splash guard. And for complex cases, we still use both 3D printed models and virtual models. And there are advantages to each, I think. I think eventually, due to costs and due to the delays that are involved in 3D printing these large models, we will move more and more towards the virtual models. This is the same patient from a previous slide. For these operations that involve many approaches, you are able to minimize facial incisions and accomplish what was once difficult maneuvers with much more confidence. And I'm always pleased to see that the results are actually very close to the preoperative planning. So we've seen the use of technology in complex cases. How about routine and simple cases? For example, this is a common case. This is a patient that came to the ER with a simple cheekbone fracture. This right-sided cheekbone here is broken. A nice trick is to generate a mirror image of this anatomy and use this mirror image as the guide for repositioning the right-sided cheekbone. Blue here is the mirror image of the unfractured site, so we're using it as a guide to rebuild the bone. Don't use red. You'll have a hard time seeing it in a bloody field. This is one thing that we've learned the hard way. Here it is overlaid on the patient's anatomy. The surgeons in the audience that treat these fractures know that we try to do this with very small incisions, with limited visibility underlying the anatomy. Again, a common cause. In this case, augmented reality allows the surgeon to do a lot through small incisions. Our cardiothoracic colleagues are exploring using this complex chest reconstruction, are using it in this type of case and different types of cases. The video on the left shows how we place our virtual landmarks for registration. The video on the right shows the reconstruction sequence. Again, all this is done with voice commands. Another application we're looking at is rib fractures and the possibility of using augmented reality to visualize and approach the fractures through minimal incisions, and perhaps put a small plate there or bone glue. Our neurosurgeon colleagues are also interested in this technology. I think a key test of novel technology is whether it gives us something we've never seen before. Here, for example, we're looking at the undersurface of the skull, looking at the impressions left by the brain and the major vessels. You can also plan your cuts in a similar fashion. And every once in a while, you'll see something truly intriguing. For example, here, this is a view of the base of the skull with the brain removed. You never see this in reality. You cannot remove the brain. I've only seen this in the anatomy labs, doing cadaver dissections. I think our base of skull colleagues that operate on this area would be very excited to have a visualization tool like this. So now we routinely plan our bone cuts while wearing the HoloLens to use this ability to see through the skull and avoid the major vessels. The superior sagittal sinus that you see here in red is a big vessel that has a tendency to grow into the overlying bone and is vulnerable while making bone cuts. Our neurosurgery colleagues are now collecting data on the blood loss during this step and will be presenting this data soon. This is another thing that I've never seen before. These vessels here, those little vessels that you see, are inside the bone. There's currently no other way that I know of that you can visualize these vessels. For example, here you see those 4 vessels coming together, and instead of cutting through those 4 vessels, we just moved our bone cut 1 centimeter and we're able to avoid them altogether. Our liver surgeons are also looking into this, especially for tumor applications. This tool is very useful to visualize the large vessels through the liver parenchyma and to find the cleavage planes that make complex tumor removal possible. The challenge we have now is that once you've cut and moved the tissues, you don't have a way to track the parts that have moved. So we are working on streaming ultrasound imaging, intraoperative ultrasound imaging into the HoloLens device. So I will stop with clinical cases now and talk a little bit about the underlying technology. What does it take? It takes 16 milliseconds max. Your device needs to do all these calculations and produce a visual projection in 16 milliseconds or less. Otherwise, it will not feel real, you will get dizzy, and you will get nauseated. The HoloLens has a holographic processor unit that can do 1 trillion operations per second. Its CPU can handle about 800,000 triangles, which is not a lot, by the way. So you do have to be careful about not displaying a lot of data. You have to be selective with the data that you present. But it's really amazing that it can do all that 60 times per second. This is from the Microsoft website. Essentially, here in the back, you have a cell phone processor with a battery. Here, the front is a transparent display. And there are 6 tracking cameras here with a holographic processing unit to join both. And that's it. These are the software tools that we are using. The HoloLens itself costs about $5,000, but these tools are essentially free. If you build an application on Unity, you can easily reproduce it from Microsoft to Apple to Google to others. You can also easily visualize all this data that I showed on a cell phone or an iPad. So that increases the applications of that technology too, for teaching and for other things. I will talk a bit about the process of registration, which is the process of aligning the virtual and the real. It is the most cumbersome part of the process. I've already shown the manual landmarking process here on the left, but we have also developed automated tools based on computer vision, and they work fairly well on the facial skeleton because the area is rich in identifiable landmarks. We identify the landmarks, we use computer vision, and then we align the structures to it. In areas with less landmarks, such as the limb, for example, the lower extremity, other tools are needed. And these are some of the other tools. So tracking, on the other hand, as opposed to registration, is tracking the registration in time, essentially. Tracking is still a work in progress. This is where all the research is happening. Here to the left, you can see those small Aruco markers that are used in computer vision, 1, 2, and 3. But I can tell you right off that these trackers do not work under the intense surgical light. The intense light saturates the camera sensors and we lose tracking of these devices commonly. Notice that these photos that are taken for the paper are on a cadaver with the surgical lights off. The image to the right shows the motion capture technology that I previously showed with these reflective balls that are tracked in near infrared wavelength. The technology requires a clear sight between these balls and the cameras that track them. This clear sight often gets obstructed by surgical assistance, by drapes, or by other tools. These trackers are also less precise when you use a traditional halogen overhead lighting instead of the cool LED lights because of the infrared radiation emitted by the hot lamps. Computer vision also offers the promise of markerless tracking, essentially teaching a computer to identify and track instruments and estimate their pose. You need specialized high dynamic range cameras for this work, for this to work under surgical lighting. And it is time for me to conclude. I will leave you guys on this thought. The iPhone came out in 2007. In 2016, we had our first Twitter president. Today, Apple is rumored to be coming out with their own AR glasses sometime in 2024, which is essentially 2 years away. The HoloLens HPU boasts of 1 trillion operations per second. Today, the Apple 13 Pro is capable of 15 trillion operations per second. So will we adapt or will we become the monkey? My question to you is, augmented reality is coming. Will LAU be ready? I left a lot of time for questions, so let's open the floor for questions.
Thank you, Dr. Am. Really appreciate it. Very nice, amazing, interesting. Actually, I also enabled our attendants, participants to unmute themselves. So please go ahead and unmute yourselves. And anyone who would like to ask a question, please raise your hand and then go for it. Any questions, comments? So
I
if
hope I
not,
didn't scare many people with the bloody pictures.
it was scary, Chris. I must admit. So I have a question, Chris. Do you use any AI or machine learning in terms of aligning or alignment, or in terms of figuring out how to do these alignments, or is this typically done via human intervention in a way?
So AI is everywhere in the machine. So everything from tracking. So everything here is done by AI. AI
Okay.
gives a relatively approximate best case solution. It doesn't give a precise, but this is what it takes to get this to run. It needs to be close enough, and AI is good enough for that. So it is not as precise as a mathematical XYZ translation matrix. It's always an approximation with adjustments, but it works. So anything that goes from tracking the position of the device, tracking the position of the hands of the surgeon, and recognizing the gestures, tracking the voice command and the natural language processing. All these are different, and they have their own specialized coprocessor in this. If you want to run AI or more advanced AI on the HoloLens itself, you need to bring in more hardware. For example, this process here runs on the HoloLens itself when we're aligning. You can see that middle picture that the camera is identifying the features on the face, and then it is then aligning progressively closer and closer to the face. And the same thing is going on with that picture on the right. So you use computer vision and then use that for pose estimation. This is also done with AI, but this will not run on the HoloLens itself. You will need to bring an external camera, an external tracker. Today, it's something akin to a small laptop will do this, but hopefully, again, in 3-4 years, who knows where the technology will be.
So do you think at some point we may be doing virtual surgery at some point, and then we can rehearse the surgery, and then we can do the actual surgery, or where do you think we're going with this?
So we've started using this for difficult cases at OU. And very, very quickly, we realized that for complex cases, this is extremely useful for teaching of residents or doctors in training, and for medical students. There are currently existing solutions. You don't have to individualize each of the cases for teaching. So you can do a standard anatomy course and then teach it to the medical students. But for surgeons in trainings, it really expands their comfort level. So you take a resident, you ask him, do you want to do a facial, a facial reconstruction case, front orbital advancement? And the guy will look at you with wide eyes. But after you walk him through the case virtually, and you ask them the question again, and everybody's ready to go. So this really has important implications in teaching and training.
Okay.
And this is really the next stage of this.
Okay. Thanks.
So I would like to emphasize a little bit about this economy of triangles that we have. I think I talked a little bit about the limitations of what you can and cannot show here, with the 800,000 polygons currently limited. And this really is a call for display specialists or visualization specialists. You can see a little bit of roughness here in the skin. We don't really need the skin. Whereas when we get closer and closer to the structures that matter, the vessels, etc., here, you can see much more detail into that. So this progressive complexity, more and more granularity as you get closer to important structures, is something that a visual graphic artist knows about and is more able to design these visualizations much better, really.
Okay. Okay. Good.
I have a question. Hi there, Chris. I have a question.
Yeah, go ahead, Joe.
Hey, Joe.
Yes. Hi, Chris. You know the situation in Lebanon, as you come very, very often here. It's very bad. To my pleasure, I see that some students are attending this talk. We have students from biology, I could name Mary Jo Abismaan or others. We have students from computer science. Could you address probably in a minute to those students, what are the opportunities and the venues that augmented reality and your work as well could do to them?
So for students in, this here was a call for action. When you see this, all these tools there, they're essentially free. All you need is your imagination, a little bit of coding knowledge, some friends at the computer science department, and you can design very early on and be on the early wave of this technology. There still today, the FDA has no regulations for this. So the earlier you are on the bandwagon, the bigger your voice and the higher your chance of breakthroughs. This is as an academic opportunity for advancing medical science, but it's also an economic opportunity for recent graduates. And LAU as a university should be ready and prepared for this. Everything from multidisciplinary collaborations between medicine, engineering, computer science, graphic design, everybody needs to be on board. Multidisciplinary teams to put these things together. And the tools are not inaccessible. Essentially, these tools exist at LAU now. I know that for a fact. And you have faculty and you have students that are willing and able to go through this. Come up with the applications and be early and innovative in this field, and the sky's the limit, really.
Okay, thanks. I think there was a question from Dr. Talib.
Thanks, Haidar. Thanks, Chris, as well for the presentation. And hi again. I wanted to ask actually a couple of questions, but I think the first one you already answered with Joe. I wanted to see exactly what should the students do actually, where should they go, what type of software should they look into, but I think you actually answered that question on the slide that you're already sharing. Should they actually feel that they actually want to get onto this bandwagon? And I'm like you as well, I don't plan to becoming the monkey of the 2025 era as well. So we've been working extensively on AR, VR. But since we've already answered the questions with regards to the students and if they actually intend to get onto the AR bandwagon, what to do. But my question to you now is, as LU, as a university, what do you think our next step should be in this particular case? Because you're already familiar with some of the hardware that we already have, you're already familiar with some of the work that we're trying to do. What do you think should our next step be in this particular case if we want to actually really get on board to what everybody else is doing worldwide and not just sort of like at a smaller scale?
I think number one, LAU has a chance to be a leader in the field. Not everybody else in the world is doing this. Few centers, mostly in Germany, in the US, Cleveland Clinic, major leading centers are doing this. They're putting together a program with multidisciplinary actors, people from all the disciplines that can benefit from this and put these together. So this is really a chance, an opportunity for LAU more than anything else. What needs to be done is, number one, create student interest and create pipelines for those students to go through, both inside of campus and outside of campus. Build a connection list. And we, again, you guys, I know for a fact that you guys are doing a great job with that. But also a pipeline inside the university with different programs, special tracks for students to follow. Again, I will not get into that. This is more internal for LAU. But again, multidisciplinary tools create interest and create a pipeline for the students to go through. I hope that answers your question, Robin.
Yeah. No, does, and if you allow me just 30 seconds, Haidar, if I may use this platform just to tell the students that Chris was saying that we just need to create student interest, and if they want to get onto the pipeline, they can go practice their curiosity, I guess, on some of the software. Just to let you guys know that we already have an AR VR lab on campus, on the Byblos campus, and hopefully soon enough on the Beirut campus. So should you be one of those people who are interested in this technology, well, knock on my door, for example, and team members that are actually currently spending their days and nights, but a large chunk of their day in the lab, and who knows where we will actually end up in a year or two, but you're more than welcome to knock on our door. Okay? Thanks, Chris.
Thanks, Robin. Any other comments, questions? Anyone? For the shy ones, you can actually type your question. Yeah, go ahead, JP.
Okay, so hi. Thank you, first of all, Doctor, for the very nice presentation. I just have one small question. So whenever a new technology appears, especially in the field of medicine, we know there are many ethical questions that get asked. So did you and your team face any of these ethical dilemmas, and what are potentially these ethical questions that might arise from the rise of this fairly new technology in medicine?
It's a very good question, Jean-Paul. Essentially, this is, like you said, a new technology, and lucky for us, the FDA also doesn't know much about this technology and is building knowledge and is collecting knowledge. So when we applied for the FDA, we actually got a reply back that they would like us to be part of an industry group that generates this medical information for regulatory purposes. So you get to sort of write the rules as you will, which does raise an ethical question: is what can go wrong in this technology and who's responsible for that? As you saw here, our claims are not for robotic surgery, for stereotactic surgery, or for surgical guidance or surgical navigation. This is a separate engineering problem that requires much, much higher precision. And I think the virtual reality and the augmented reality technology is not there yet. Instead, what we presented are simpler tools that fit into the current armamentarium and complement it. So if you're a doctor, you know how to do this operation, but you'll be much more comfortable if you have this technology. Currently, when we do these very fancy surgical planning sessions, you can plan any surgery and then reconstruction and the reconstruction virtually. But you reach a point where you have to print them on 3D paper, on 2D paper, and then take a piece of tape and stick them to the IV pole. If you have a nice screen in the operating room, you can put it on a display screen and then do that. But you're still disconnected from the surgical field. So intuitively, the surgery is more helpful. When we tried to explain this to the IRB, our institutional review board that reviews the ethical questions that are raised, we essentially told them that we could take the technology away and nothing would change at surgery. But it is very similar to taking your iPhone away and asking you to do email or asking you to do routine tasks nowadays. It's so useful that you'll feel less capable and less functional without it. And that's the way it is with this technology. It is an augmented technology. It is not a replacement technology. You're not a robot, and the headset is not a robot. It will not teach you how to do surgery. It will help you do it though. But this is a very, very important question, and the answer is we don't know yet. And lucky for us, there has not been any major incidents with people using this technology. But once that happens, you'll know that we'll have to look much closer at the ethical questions.
Thanks, Chris. Any other comments, questions? Okay, I guess this is it.
I have one question.
Go ahead.
This is Dr. Paul Haj. I'm a neurosurgeon. First, I want to congratulate you on this very interesting topic. You know, usually as a neurosurgeon, we use the neuronavigation during surgery, but we know when we operate on the brain, there is a movement of the brain once we open the dura. When you use this augmented reality, can you correct this displacement during the surgery?
So this is the problem of tracking, and as you've already stated, this surgical navigation technology fails when we do tracking of soft tissues. So what we're trying to work on is now stream intraoperative ultrasound to the HoloLens. So you will be able to visualize live data from the ultrasound into your HoloLens. So we're using a regular intraoperative ultrasound. You put a sterile probe on top of it, and a probe cover, and then you stream the images into the ultrasound. The problem is that we're getting a very low, we're not at 30 frames per second yet. We're much lower. We're at 12 to 15. And hopefully, once we get a good networking solution, we'll have a higher frame rate for that. That's currently our limitation. And once you're that low resolution and then frames per second, things become awkward. They're not as practical as they can be. And then also,
okay, thank you.
I think Paul, you raised a very important question, which is how reliable are the technologies, surgical navigations and others? They are sold to us as a millimeter or less accuracy. Once we've connected the HoloLens to it, we've realized it is not that precise. There is often a lot of movement and incorrectness in the solutions. You know, somebody bumps those markers, or they're sat on, etc. So, and then the whole registration goes wrong. So they are much less accurate than we thought initially.
You know, when we are at the level of the skull base, when there is a bony structure, there is no movement. The correction is approximately 1 to 2 millimeters. But once you are in the brain, you know that the cerebrospinal fluid movement, and once you open the dura, all the brain moves from the initial position.
Yeah. So what we're trying to do is take those ultrasound probes, attach markers to them, and then use them to stream intraoperatively. I don't know if that would
okay.
But again, one of the main things is, one of the things that I really wanted to hear was questions from the audience is, how would I use it? How would I use it in surgery? And this is an important question that you raised. And I would like to add that you already have the expertise at LAU today to find a solution for your problem. You have engineering, you have computer science teams that are able to develop this technology today.
Great, thank you very much.
Thank you, Paul.
Thank you. Okay.
Chris, I have a last question.
Go ahead, Joe.
Yeah.
Okay. A lot of us attending your talk, the very interesting talk, and thank you very much, would like to meet you in person. And I know that there is a chance that you will be in Lebanon during the holidays. I would appreciate if you let us know when would you allocate like half a day or a couple of hours for anyone from LAU who is interested to meet you in person. Thank you, Chris.
Joe, thank you for the invitation. I would love to meet with as many people from LAU as possible. I am from Jbeil and I love Jbeil, so I apologize for the Beirut campus folks, but I will be available in Jbeil for anybody and anyone as soon as I land, I promise.
Thank you, Chris.
Sure.
Okay. Another comments, questions, remarks, observations? Okay.
Hello.
Dean, Janette, and yeah, go ahead, Dean.
I just got the electricity back, and I think that means you can hear me. Thank you so very much for this wonderful talk. I heard everything, but and I watched everything. I just couldn't participate in the Q&A. Really grateful to this talk and really looking forward to getting many more students and many more faculty in a huge auditorium, so you can hear some more about your wonderful achievements. And please do let us know. We'll pick you up from the airport just to make sure you come to LEU first before you go anywhere else. Thank you so much for your time, and thank you to everyone who joined us this afternoon. Really sorry for seeming to be absent, but I was here all the time.
Thank you, Dean. Thank you for hosting me. I appreciate your time and attention and the very thoughtful questions. And my email and contacts, I will make them available to all. Haidar, Joe, maybe you can help with that. And hopefully there'll be many more talks after this talk.